Well, good afternoon, everyone. I'll assume we've flung open the electronic doors and everybody is free to join us. I'd like to welcome you to the third and final installment of our series exploring the stories and impact of Wisconsin's immigrant workers. The series was organized by our friends at Alverno College and co-hosted by UW-Milwaukee's Center for Latin American and Caribbean Studies and the Institute of World Affairs. I'm Doug Savage. I'm director of the Institute of World Affairs, and we are very pleased to be able to bring you some perspectives from frontline healthcare professionals about their experiences serving immigrant clients, both during the pandemic and beyond, more generally. I'm sure their remarks will generate questions, and I would ask that if you have a question, you just put it in the chat. And time permitting, we'll then recognize you by name and you can unmute yourself and ask your question in person. So with that, I'd like to just introduce our panel, three of whom come from the 16th Street Community Health Centers in Milwaukee. Gabriela Dieguez Hurtado is a bilingual therapist with 16 years of experience at the center. Annie Yanish is a social worker at the Center's Social Services Department. She's actually on her second stint at the center, having first worked there for 12 years, beginning in 1997 and then returning in 2017. Itza Vargas is the 16th Street Community Health Center's Director of Nursing, and she's actually another 16th Street returnee, beginning her career at the clinic in 2003 as a medical assistant, working there for 13 years. And then after earning her nursing degree, she worked as a intake nurse at a med-surg unit. But I guess that the pull on your heartstrings was too great and you returned to 16th Street in 2019. And our fourth panelist, Netzali Pacheco Rojas, oversees mobile medical clinics in rural settings as mobile health practice manager for Family Health La Clinica based in Wautoma, Wisconsin. So with that, I would invite our panelists to just give us some sense of what the last few years have been like. So Gabriela, perhaps you'd like to get us started.
Thank you so much, Doug. So the past 2 years during the pandemic have been very challenging for immigrants. In behavioral health department, we were able to switch to telehealth, which in theory works pretty well, but then we have to think about what are the challenges for families that have low resources. So we struggle with having enough bandwidth for communication with clients. We also struggled with the payment from insurances at the beginning. Now those things have been established, but I think it continues to be one of the challenges of telehealth. How we can make it affordable for all clients in the community, and how also we teach our families and the people that we serve that this is a way that is still confidential to seek services, and that it can be a way when people are struggling with transportation or being sick and still being willing to have a session for mental health. So I think there's a lot of work that we can do. And one of the great things is that at the federal level, there is an agreement for coverage of telehealth services. One of the greatest learning things that we did at the clinic was having to do phone services for mental health. And I confess I don't like them. I think there's a lot more in sitting with someone in front and being able to sense the energy and gather information through what I am observing. It's not the same to have someone cry on the phone and not being able to really be present with them. So I think it's a new era. We all have to adapt, and there are things that we are learning and that we are changing in order to satisfy the needs of our community.
Well, that's great. Annie, maybe you'd like to tell us a little bit about how the world looks from where you sit.
So yeah, being a social worker is always, challenging, and working with people who have limited resources, who are, language barriers to services. But of course, as Gabriella said, the pandemic's just made everything more challenging for everyone. And I think, immigrants were especially hard hit, due to, the same issues that, that many people were faced with, layoffs, losing jobs, hours being cut, and getting COVID and losing time from work. But, all the other questions that come up is, in terms of, what benefits or their assistance are they eligible for, and maybe they're not eligible for certain benefits because they may not be legal residents in the country. And all the different, language barriers make things harder in terms of the school needs, and being, all of a sudden, being teachers for their kids at home is really hard. And the social work department at the clinic actually was, we were sent home about, I think the last week in March of 2020, which was very different. Like, I had actually never worked from home, and really wasn't set up for that. And so just dealing with, setting up computers at home, and the dogs and the cats, and the main thing was we didn't have set up for telehealth, so it was all phone contact with patients. And so doing, either calling people from our home phones, and then, as people do, that, the number shows up on their cell, they call back, and or doing the thing at star 69, so it's a private number, but then they always say, why didn't answer it, because it's a private number. And like Gabriella said, just the limitations of not having that face-to-face, sitting with someone, and just, attending to their nonverbals, and just having that warm physical presence is difficult. And additionally, especially if there's safety concerns in the home with something like, family violence, if we're talking to someone who may be a victim, is the perpetrator in the room, they might say, yeah, it's a good time to talk, but how do we know that? And so, yeah, we definitely had to adapt in many ways, because of that. And then just when we did have contact with people through home visits, a whole other host of safety issues. And, maybe is it more at risk going into the home, even though we're masked up, and, to have them sign a paper. So, yeah, definitely a lot of adjustments to be made across the board.
Thank you. Pizza.
Oh gosh, where to begin, right? When I was first approached about this panel, right, it was about immigrants working in healthcare, and how they have managed through the pandemic. And for me, it was hard to differentiate between the healthcare workers and the rest of the community, because a lot of us are from this community, right? And a lot of the issues that members of the community were experiencing, we, the healthcare workers serving here, we're going through the same thing. 16th Street Clinic, our centers where they are located, we are right in the heart of Milwaukee and the South Side. When COVID started and the numbers really started climbing up, the two zip codes, 53215 and 53204, were considered hot zones for COVID. And that's where we have two of our biggest medical clinics. So we were right in the center of it. And so, from the first case happening in the city and being confirmed within a week, our first COVID testing tent was up and operational. And so, while the community was figuring out, what do we do? How do we do this? We were on that same boat as members of the community, right? As our family members living here, as our kids attending school here, but also understanding that the care we provide is vital and important to the community in Milwaukee. And so understanding and figuring out a balance of, we have family members who are getting sick, we have kids who are not able to attend school, we had the same issues with childcare. However, we couldn't slow down, and if anything, we picked up, all of our efforts went into, let's put on hold physical exams and well child checks and all this prevention stuff, because we had to put all of our focus on that moment, right? Reacting to the pandemic and being there for the community. And so the clinic did not close. Many places were closing down and laying off and furloughing, and we were busy every day. There was not one day where clinicians and MAs and nurses were not here testing, seeing patients, calling with results, getting in touch with social work, getting them in touch with behavioral health because of the needs. And again, a lot of our staff members, many of us, myself included, were patients of the clinic before we were employees of the clinic. And so we've relied on the services the clinic provides. And as immigrants in the community and as immigrants working in healthcare in the community, it has been an eye-opening experience, a learning experience, but it has also been very humbling to know that we have been able to continue to serve our community and provided the same top quality and care to our less fortunate patients, as well as those who have, a little bit more of resources available to them.
Well, those are perspectives from a more urban setting. That sounds like what did things look like in the countryside?
Yes, yeah. I think a lot, very similar things for my three presenters here as well. For me, I think I really wanted to point out as well that for us, transportation continue to be, something that is difficult for the population, for immigrants in Wisconsin. If you're undocumented, you cannot get a driver's license, and we were able to see that as a barrier for our healthcare workers. It really looked like you didn't quite stop working once you were done at work, right? You were the one who had the knowledge and how to work the healthcare system. So when you went back home, you had your family call you. You were the ones who had your friends and family be like, hey, like, I think these are the symptoms. What do I do? You were that guidance. So not only were you working extra hard at work with increasing services, especially like pivoting and doing that COVID or scaling up COVID services. For us, it was testing and then vaccination, but also a lot of our workers were doing the exact same thing for their families, for their friends, for their communities that were around them. In a rural location, we had that difficulty of network connectivity as a lot of things began to move more towards telehealth. We have a higher population in regards to older folks, and there was a IT literacy that needed to also be picked up in regards to how can we help in that as we also transition our services to telehealth and phone calls and all of that. So it was stages of whirlwind of like learning something new, transitioning that, seeing that sometimes it was a bit of a hurdle for our immigrant population, whether we had to have 3-way phone calls for a Spanish speaking interpreter to be part of that, and then going all over again when something new popped up. Yeah. And then lastly, like on my end, I do mobile services. So we have the opportunity of helping a very unique population. They're called the migrant seasonal agricultural workers. And this population was deemed essential extremely early on in the pandemic. And what they really do is they come from either different states or sometimes through a visa program to the locations and work in the fields, work in food processing in regards to like getting your canned goods and everything. So they were essential in making sure that we had food during this whole entire time. I mean, in the beginning, everybody panicked, so it was extremely needed. And for us, we felt the need to really pick up relatively really fast on how can we help the population, because they had a lot of the same things we were seeing with our regular immigrant population, but because a lot of the times they're not local from Wisconsin or within their community that they were around, they needed extra assistance in trying to find local locations and trying to find that place in rural Wisconsin. It's difficult to find a lot of unless you know it, that those pockets of his Spanish speaking speaking or other immigrant speaking, right, communities. It takes a while to do that because a lot of the times we tend to hide. And that was difficult for this population. Sometimes a lot of them actually end up living in close quarters. So the whole isolation looked different. The way that they worked different. And it wasn't just us. Like I know a lot of immigrant workers also work in like the food processing locations and factories, and social distancing in those locations was really difficult. So we went back and forth on how a lot of learning through these past years in regards to that.
Well, thank you. And to our participants, I would encourage you, if you've got a question, to put it in the chat. And in the meantime, let me follow up on something you just said. How did the nature of the kinds of work that many of your clients do impact your ability to sort of intervene? I'm thinking there's a case that comes to mind in which people working in meat processing requested that the line be separated a bit more so that workers were not shoulder to shoulder as they usually are. And they were told, oh, no, that's not efficient. We can't do that. So talk a little bit about how the nature of the work impacted the situation.
Yeah, so we became advocates for the patients, advocates in general, right? So on our end, it was for the better of both parties in regards to making sure that the workers remained healthy. And that was a key implant. We saw that a few locations early in the pandemic ended up getting COVID, and it just spread like wildfire in regards to a lot of these locations, right? So we used that. We were like, hey, like if you're able to separate them, if you're able to provide those face masks, and later on they were even like separating every other one instead of being shoulder to shoulder does decrease. It is proven. Transitioning, it was a lot of conversation and trying to work with the employer as well to what was available in transitioning shifts for eating, because sometimes everybody would just like, half the group would break, but that for the break room was tiny. And really thinking every step of the way. At the beginning of the pandemic, we one of our medical providers actually was able to go to some of these factories and look at the full process of like from each station that the workers are part of and be like, this is what you can do to mitigate the risk early on, really trying to get those PPE, getting all of those guidances so that the employer could see the importance of it.
A little bit in regards to that, if I may add, a lot of those workers who were deemed essential workers, right, in factories and in some food markets and all of that are spouses, relatives, family members of those working in healthcare. And so it was in that way that it was affecting, a lot of our staff members working in healthcare, because now they're family members who could have potentially helped with taking care of the kids who are now virtual, weren't able to do that, right? Because they're working, they're essential, so they're out there too. And at the same time, maybe in healthcare, we were being a little bit more cautious in how we were approaching the day and having that PPE. And a lot of those factories and work settings were not. And so it was that risk of now you have, at the end of the day, everyone comes home, right? And some of the essential workers really weren't being protected as they should be, thus then putting our staff members at risk and some people getting sick. And now we didn't have the staff to be able to continue working while still staying open and being able to serve and test and provide education and treatment, right? And then vaccinate. And so some of those struggles that we saw within the community with other essential workers and how the schools were affected and daycares and transportation, right? Public transportation became an issue where a lot of our community members rely on that. And to not have transportation, not be able to get out, then our healthcare workers who needed to be here were kind of the ones driving family members around. And how do we provide to our families, stay healthy, and still take care of the community? So all of those things were intertwined, right? It's really hard to differentiate immigrant healthcare workers from immigrants in the community because it's all tied together so closely, right? I asked to have Gabriela and Annie participate in this as well, because, and obviously for confidentiality issues and stuff, we can't share, but I am sure that they served in with the services they provide, some healthcare workers and their family members, for the needs that at that moment, the resources were less in a lot of areas, and they needed to resort to getting help from social workers and needing to see a therapist for the different things they were experiencing at work and at home. So it's all very closely knit and still coming and showing up, right, for what the needs were at the moment, and still are within the community.
So
I
what?
wanna- oh,
Oh,
sorry, I
sure,
just wanted-
please, go ahead.
I just wanted to touch on something Itza said as well about, companies or workplaces where there are, many immigrant workers not providing proper PPE, excuse me, or social distancing. And people are, I think for a lot of people, it's hard to speak up to a manager in a workplace, but especially people that maybe are working for cash, or maybe working under a different name, or just don't feel they have the power and the social capital to really challenge that and speak up, or they literally may not be able to communicate with anyone at work. It's maybe one or two people because of the language barrier as well. So that definitely creates a tough situation. If they're being exposed or somebody gets sick, then again, everybody gets sick. And so.
And what, within your facilities, what was the situation with regard to your access to PPE and the height of it?
I thought it was excellent. I thought our clinic did a really good job of making sure it was available, making sure all that stuff was enforced. I mean, we're still wearing masks to this day, which I think is probably standard among healthcare facilities. But and I think just from practical purposes, just figuring out like, okay, what kind of masks you need, and kind of the struggles everybody had. But again, especially once the social service staff returned to the office, they made sure we had what we needed. But I'm sure not all places are as diligent. So.
Yeah, so on our end, we had a good stock in regards to the starting of it all, but right as we continue to order, everybody wanted to order, and as it began to happen, we began to see that everything was either back stock or out of stock, and it was I think a very stressful situation for those who did have to have that responsibility as healthcare workers to figure out how are we going to get it, because at one point in the pandemic, even though you were like properly stocked at the beginning, everything seemed to just look like it was all back order. It was a lot of work through the reps that we ended up working, and even the state too, that later on helped and assisted a lot of the community health centers. But yeah, it was, I think, an added stress for some at the beginning, but also like even during it, as we began to see the surges.
Yeah, I mean, there were the really alarming photos of healthcare workers in like trash bags and things because they didn't have proper, PPE available to them.
I'd agree with Netzali, and I'd be happy to say that we did not resort to trash bags as PPE. Thankfully, we were stocked right as we would be for our day-to-day when things came up. It wasn't because it's primary care, right? Prevention and education and all these things, and to react to a pandemic that unfolded so quickly, really, from when I was like, all right, this is a real thing, to the first case in the US and the state, and then it was just in our faces, right? And it was exactly that, as Netzali said, we were okay, but then going, oh, we're gonna need to get some more, and really following, keeping up with the CDC guidelines and making sure that we were doing right by our staff and their family members and our patients, right? Because again, we wanted to continue to be here for the community, and protecting the healthcare workers was essential. We wouldn't be able to do that if we didn't have the staff here. And so it was at times very challenging. We did receive donations from nursing schools, from medical schools. They're like, hey, we're not using this now, right? Our students are not coming, and you guys need this more. And that was great to see that camaraderie and that support from some of these schools saying, use it, protect your staff, do what you need to do. And so we did use up a lot of of what was donated to us, shields that were being made, put together somewhere, and they bring boxes. And that was very helpful until we were able to get a par level again back in our routine.
So hopefully this confluence of unfortunate circumstances will not happen again for a very long time. But having gone through it, what sort of lessons learned would you say you could look forward to if there's something else on the horizon that you need to respond to?
Well, I think in behavioral health, we need to start thinking about how we create communities, because having a community protects us all, us as providers, but also the families that we serve. And in the setting that we work is both of them. We serve our own community, we are part of the community, our family members work in the community. So creating those stronger ties, I think, is one of the things that we are called. The pandemic has increased the need for mental health services. We are seeing a lot of depression and a lot of anxiety. So we need to create different ways of satisfying the needs of the community. And I think in part is doing a lot of education to the community, but that we as a community together talk about what we have lived in order to heal together and to learn together the ways of calming our reaction mode, being able to be in control of our emotions and being able to express them in a way that help us heal together.
It's really hard to think about specifics in lessons, obviously with Gabriella's point, mental health just across the board. I think being more understanding of ourselves and our peers and saying, hey, it's okay. It's okay to feel overwhelmed, and it's okay to be afraid and be, whatever it is, all of those emotions that are happening with all of this, and get the help that you need. We have the resources here and we're telling our patients about it. Let's use them for ourselves too, right? Like it's how it is at home. If you don't take care of yourself, how do you take care of others? And it's the same with that. I think for a while, hearing healthcare workers, the frontline workers are heroes, kind of put that pressure on people of okay, we really have to step up and we can't do anything else. It's like, no, you can take off your cape and and all that stuff and say, hey, I'm vulnerable too. I have fears, I have questions, I need a break. And having that grace with each other. But in regards to responding to something like this, I think one of the pieces was understanding, even though technology is just part of everybody's day-to-day, is understanding how our patients use and understand technology. I don't know how many times we would say, we just need your email to send you a link, and they have a smartphone. They're like, I don't have an email address. And it's like, yeah, you have to have an email address to be able to use this smartphone, and sitting there with them and getting them an access, like, this is your email address. I'm going to send a link to this email, and doing that teaching, because you go to the store, you get a smartphone and you can have Facebook, but you don't know what else there is to do. And then understanding, okay, do they have internet at home? Do they have that availability, right? With kids going virtual, some of them were able to get that free Wi-Fi service for a while so that kids could connect to school, but they didn't have that. And it didn't necessarily become part of our questions to our patients on day-to-day, like, do you have access to internet? Do you have access to, if I have any teaching tools or any like helpful pages for you, for your kids, do you have that? And we learned that when it came down to virtual, right? Like, we want to do a video appointment. We want to see you, you have COVID. We need to at least make sure that, your breathing looks normal, that you don't look like you're in distress. And they weren't able to connect because they didn't have internet, because they didn't know how to, like, the time spent, now click on this, do this. It was like their whole appointment time, but we couldn't hang up and say, we're not going to see your appointments up, right? We still had to see them, and really learning that a lot of our patients don't have that access. And so, as Iwa said earlier, it turned into a phone appointment, which was fine, but it wasn't as good as laying eyes on someone. And so just understanding as a community that really there are a lot of things that have to improve in general, just when it comes to equality and equity of services and what people have access to. Not speaking the language, not speaking English, not being able to read, not having that educational level or that social economic status of being able to afford a little bit more should not put you at a disadvantage when it comes to being able to receive that quality healthcare, that everybody should have.
Well, we've got a question from our audience, and the name is just Lopez S. If you would like to unmute and ask your question.
Sure. This is Sylvia Lopez. Thank you very much. My question is, how much reluctance, if any, did you see to getting the vaccine? And did you have to counter misinformation in your communities? Thank you.
Most, like everything else, right? You get sources and you hear things from everybody. And so there was some reluctance from I think just in general, from some healthcare workers in general, from the community in general, just understanding, that this was something new. And some people were seeing it as we're not, lab rats, they're testing on us, or, and it was one of those things where I felt like we are in an area, working in an area that is based on science, right? And if we're doing this, is because we trust the science and of what we do. And like everything else, we have to lead by example. And so at first there was reluctance, and a lot of it was just where they were getting information from, right? Like so-and-so got the COVID vaccine and then they got sick and this happened. And it's like, okay, well, so-and-so had these comorbidities when they got sick, right? Like there was other things to it that people don't necessarily put together because they lack the knowledge or just don't understand how things, contribute to other things happening when it came to illness. But we did, as an organization, understanding that a lot of our patients are Spanish speaking, we launched on Facebook. It was called Pregunte al Doctor, Ask the Doctor. And it was Spanish speaking individuals. They could ask anything they had about COVID-19, the vaccines. There were, let me look at the numbers so I'll make sure, 13 events. We had 21,000 video plays, 41,000 people reached in 2021. So the community wanted to know, they wanted to be sure that what we were doing, right, was the right thing. And we've been able to date to vaccinate more than 25,000, give more than 25,000 vaccines since we started vaccinating, right? We were one of the first ones nationwide and the first ones in Wisconsin to get President Biden's COVID-19 vaccines when that program launched. And we quickly vaccinated, and understanding that, there were tiers as to who could, those first responders, there was like tiers as to who should get vaccinated. And at the end of the day, we were being cautious and judicious. We didn't want to have anything go to waste. And because we understood that our healthcare workers, many who are immigrants, who have family members in the community, cared not only for themselves and their patients, but for their family members as well. At the end of the day, I would say, I know we're following certain tiers, but I'm not throwing these 3 vaccines away. Does your wife want to come in and get this shot? Does your husband want to come in and get this shot? Does anybody want to come get this vaccine, right? Because it was important that in order to protect our healthcare workers, we also protected those in their home, right? Because if they stayed healthy, then they could stay healthy and everybody could show up and do what we needed to do. And so there was reluctance, there is still reluctance, but I think that people are understanding that this is just kind of the way to go, right? Some people who have been fully vaccinated and have received their boosters, we're seeing that as they're getting sick, COVID is still around. It's not hitting people as hard as it was at the beginning. And I think that's just across the board, understanding how to treat this virus and how to fight it, and what education pieces are important, and quarantine and all of that stuff, right? At first, it was scary. It was a lot of fear, a lot of hesitancy, but within the 2 years of time that has passed, I think the mentality for many has changed. And I think it shows by the numbers that we're seeing.
Well, one of the things it seems to me that must have greatly aided your work is just the reservoir of trust you had built up with your community over a long period of time. What advice would you have for providers who are seeing people from similar communities for the first time who wouldn't have that relationship, who are, you know, just the first contact with these people? And what are the issues they should be aware of when they're trying to help these folks?
I didn't want to take the spotlight from Natalia. I don't know if she had anything to share. I mean, Gabriela and Annie, feel free to join in as well. But I think the providers in our clinic have been able to develop that trust because we meet patients where they are. When they come in, it's not about, here's what you have to do, see you in a month, right? This is what I think. What can you do from here? Let's work on this together. Let's develop a plan. Let's, this is a collaborative. We're partners in your care and in your health. And I can speak for the majority. I think that the Latino community, the Hispanic community in our countries, doctors and clinicians are seen as someone with authority and someone who is respected greatly. And so a lot of the times is the doctor said this and I should follow, right? And trust it. And I think that the providers, the clinicians, the nurses here at the clinic understand that. And it's not something of, I have that power and that authority, but rather use that respect that they receive as a way to, like, what I say to them matters. They trust what I say, but I need to be able to match them where they are, right? And understand where they are. And that's why it's important to understand their educational level, the resources that they have. What is your living situation, the social determinants of health, right? Because there are so many things that impact the way an individual approaches their health, and understanding that and having providers and staff members who understand that and meet the patients there is huge. It's important. We have patients that have been here for families, generations, like pediatricians that have seen kids grow up and now they're seeing their little ones, right? Like, it's just an ongoing. We've been in the community for over 50 years, and I think, and we've grown a lot because of how the community sees our clinics, our staff, and what we want to do and keep doing for the community.
And I think when meeting with people for communities that do not have the experience of working with Latinos, I think is practicing cultural humility, like Itza is saying, is being curious about who the person is, and really paying attention to what are the strengths, because immigrants bring a lot of gifts to this community. So keeping that in mind, that it's not only our needs, but it's also all that we contribute to the economy, to employment, to the functioning of this community. So I think practicing with cultural humility, being curious about who's this person, what they bring to the story, and what are the resources that they already have to deal with the challenges that are presenting at the clinic.
And if I can jump in too, it's so true, because I think there's a certain maybe stereotype about the Hispanic community is this, like XYZ, or like, and I know in many ways, many Latino American cultures or Latino cultures, family is very important, but you always have to ask and you have to listen, about what's going on with their lives. And you mentioned Itza about social determinants of health. You took the words right out of my mouth, because that's social workers have known about that for years, but it's sort of a newer type of terminology. So I'm glad that doctors and policymakers are becoming aware of how health impacts your socioeconomic and housing situation, and then how that in itself impacts health and everything. Because I work with many people who are doubling up or living with family because they cannot afford their own apartment, and some of the reasons are due to disability or people waiting for Social Security. Other times, a lot of it was due to the pandemic, or maybe people unable to work, or they lost their job, and a lot of them, they're helping out their family members, but they don't. I work with a lot of older people that say, I don't want to live with my daughter and son-in-law and my grandkids. I love my grandkids, but they're driving me nuts, and I have no privacy. And and I think there's, especially not coming from a Latino background, and maybe having this sort of idealized picture, like, oh, we have grandma and mom and dad and the kiddos under one roof, and everybody loves each other and is making tamales every night. And I think a lot of people too, they want privacy. They don't want to all live in one place, and they deal with the same frustrations and stressors as anyone else does, even if they do have that strong family bonding as well. But and I think, getting back to your question, Doug, about like what we've learned from this whole experience, and I was actually really heartened that, even though of course there's a huge sort of part of the population that's maybe really wasn't on board with the concept of thinking of other people and protecting them and protecting yourself and that kind of thing. I mean, I'm humbled by the outpouring of generosity that we've had. We've had a limited sort of patient fund for people affected by COVID who lost their jobs, or, I mean, a lot of people, you lose a few weeks from work or less, and you can't pay your rent, because if you're making, $10 an hour or something, it makes it pretty hard. And so we've been able to step in and also refer to, the community advocates, which does the federal funding. So getting people some help that they need from sources that were not previously available before the pandemic. So there's more need, but there's always been that need. And and a lot of people, they seem to get it, like, well, hey, people are at risk of eviction. It's not their fault because they got sick, they got COVID. And I always say to them, well, that's true. And it's always been true. There's, and you can say, well, there's bad actors, or there's people that don't do this or that. But I mean, people get sick or disabled, or they just struggle through no fault of their own. And it's a very unequal society. And so I'm hoping, I doubt it. I mean, I'd like to be optimistic, but I mean, I'm hoping that a lot of people sort of, the lessons they've learned from COVID, and the concept of, like, we're all in this together, and let's help out, like, all of us at some point in our life need some kind of help, no matter, even if it's not economic, it might be emotional, it might be caregiving, it might be a ride somewhere if our car broke down. And having that concept of, like, it's not, I mean, COVID's one thing and it's been huge, but there's still going to be a need, even if COVID completely goes away, which it probably won't, but there's always going to be a need out there. And I hope that, there's still going to be funding for emergencies and to keep people from being evicted, because it's just so critical. That one can dream, I guess.
Well, on top of all the other challenges, everybody faced in a pandemic, could you talk a little bit about how people's immigration status could impact their ability to deal with all of these challenges?
Oh my gosh, yes. From again, I want to keep going back to, like, the focus of what this started being, right? The immigrants in healthcare. And obviously, to be able to work in healthcare, you have to have your documentation and everything up to date, right, to be here. And so the workers directly were maybe not affected, personally or to them. However, many of us have family members, or have had, or who are not documented, who live, in a different, not so fortunate situation. And so that situation affected then the healthcare workers, right? Now you have somebody who was working for cash and is no longer able to work. And now that all of that financial responsibility is falling on you. So now you can't afford to get sick, right? And yes, there is COVID leave, but you don't get paid the same amount that you would get paid if you worked your normal hourly job and got to get overtime if it was busy, right? And so all of that, having to figure out, do I continue to pay for internet so that my kids can do their virtual learning, or do I buy food? Do I get groceries? Do I get prescriptions? Like, it was a balancing act. And of course, many immigrants, we have family members, and I don't think it necessarily pertains just to Latino and Latin American countries, but immigrants in general, we leave family behind, and a lot of them rely on a little bit of the financial support that we can send. And when our financials are struggling, how do we support others who, again, pandemic, right? So they might be struggling as well in their home countries, and now they're unable to work and very much relying on what we're able to supply. But we were struggling through the pandemic here too. So financially, it was making decisions that were difficult to make. And so a lot of those things happening in the community, obviously, were also affecting our healthcare workers because of our families, because of who we are in the community. But it was difficult to take care of our patients who were in that situation, because they could have been very mildly symptomatic, but still, you had COVID, you can't go to work. This is your excuse. And they would ask, can you shorten my time? Can I go back sooner? We cannot. We are following guidelines based on your symptoms. We need to hear from you every couple of days to make sure that you're clear. And, just, it was a lot. Again, it's been a learning experience because it's changed, right? Like the recommendations change, and when you can return on which symptoms you have. If you don't have any symptoms at all and you just got tested because you know that you were exposed and you came back positive, when can you return to work if it's one of those, cases where you feel great, but you could still be contagious and it might hit me harder than it hit you, so we would know, right? And so it was very difficult to tell someone, I cannot give you an excuse to return sooner. Because we need to be mindful of what we're doing here, right? We're taking care of a community, citywide, nationwide. And to tell someone, they say, well, I'm going to lose my job. And employers then were calling to confirm, did you see so-and-so? And confidentiality, I cannot tell you, and can you fax this to us? No, we cannot fax things to you. Like we can get it to the patient and they could get it to their employer one way or another, have a family member take it. And so was very difficult for a lot of our community members. And again, some of that affected some of our workers who were dealing with those situations with their families.
I think the other thing in regards to immigration is that in healthcare, we have thousands of DACA recipients. So DACA recipients are immigrants that came as minors to this country, and now they have a social security number and the possibility of working, and they are providing services in the field that are essential for the sustainability of our community. So in healthcare, I think that if I remember right, it was more than 20,000 healthcare workers. So medical assistants, nurses, lab technicians that are in this position as well, contributing to the community, but in this limbo, immigration limbo.
And something to take a point on that too, like on a personal note, whether you have DACA or any other like international visa, the government did stop or slow down the processes in regards to how they were doing all of that on my end. Like when you filed, or I filed for all of my information, right? I had it lapsed over from when I actually had a work permit. So I went from like scaling up services, doing a lot of services, and then having to wait until all of the paperwork was set correctly, right? So not working and not getting that financial input, right? Like unexpected, because they're like, due to COVID, we are slowing down. So there's like just the position of like, as a healthcare worker, having to understand that I had to scale things up, but a personal need in regards to that, unfortunately, due to COVID, it slowed down a ton. So I definitely wanted to bring point of that. And then not just that, but also the mix family members. So like if you received assistance in regards to like some financial aid, or I think of like the first stimulus check, if you had a mixed family in regards to the immigration status, you just couldn't plan on getting that at all. And whether you had, it was like, let's say that it was a family of 5, but only one of them, let's say one of the parents was in documented, like that just, it wasn't, you were not going to receive that assistance. And that impacted our healthcare workers, our communities. As you mentioned, like a lot of them were doing more of like the boots on the ground stuff, and they either had to stop because restaurants closed or because they themselves got sick. So yeah, that financial stress. And then on top of all of that, I would also add that like mental health portion of all of it, I think it was exasperated. And I think we're growing as culture to understand more of that, right, too, because I think about it 15 years ago, the idea of mental health and as a male sometimes, like, what? Insane, right? But now, yes, like learning all of that, learning how to educate, learning how to work with our patients, ourselves as healthcare personnel in regards to like Itza, I think you mentioned taking off that superhero robe because yeah, we're human. And although I think our struggle as immigrants has allowed us to become resilient in some matters, there's, yeah, like just understanding that there's limits in regards to that.
You took that. That was what going to be one of the things I said. Immigrants, we are resilient people. That is one thing for sure. We thrive, right? We struggle, but we thrive, and that is a beautiful thing to be able to say about our people and where we come from and what is important to us and how we learn. But it's still difficult things that we encounter. And I didn't want to forget, that I know this was something geared towards educators. And number one, I don't know how you all do, if there are any educators in the audience, what you do. It really is a gift that you give to the community by educating from little ones, right, all the way to high schoolers and college level and some adults who go to school when they're adults, because it is a different position that you all are in. And so I think that it's so great that you are taking part in something like this to learn a little bit more, because what we experience, the kids, they live this at home and are not able to verbalize it and explain it as well as some of us might be able to, but understanding what a lot of our kids who are in growing up and are immigrants and coming from immigrant families, right? Maybe first generation, third generation, whatever they might be. A lot of the things they see, they don't have the same privileges as other kids. And so the approach is different, and educators and teachers and school staff members who are able to individualize and understand that it's just like we do with our patients, right? One asthmatic, you can't treat all asthmatics the same and all diabetics the same, and kids with their situations, you can't approach that all the same, right? The parent, the dynamic at home, the resources they have. And so I think it's important that we have these conversations, and it'd be great to somehow partner what happens in the clinics and in the communities with what goes on in the classroom, because it impacts the well-being of our kids, right? Physically and mentally. And so kudos to you all for the work that you do. I didn't want to end this without saying that, because I have a high appreciation for educators in general. I could not teach, and I love my kids. I don't know how you all do it. So thank you for that. You all had to adjust and learn your own way of doing virtual teaching, and then having virtual and in person, and then kind of going back and forth. So thank you to those of you who are in that field.
Well, I guess that's a good closing note to end on that. In fact, we are all in this together, whether we're in the classroom or the clinic, or preparing the food that we eat, whatever. We are all integral parts of the society, and we need to look after one another. So with that, I will thank each of you for really some very important and enlightening comments that you've made. And thanks to our participants for joining us. And throughout the series, thanks for the work that our friends at Alverno and the UWM Center for Latin American and Caribbean Studies, Institute of World Affairs, did to put this together. And with that, I would wish you a good night.
Thank you. Good night.
Thank you.
Thank you.